Hello, in this video, I'm going to talk about leg and ankle injuries, rehab, and considerations. I want to remind you that when I say leg, I'm talking about the anatomical region that goes from the knee to the ankle. All right, so ankle sprains are by far most common ankle injury compared to any other type of injury in the ankle. There's a 70% or more rate of re-injury. So what we mean by that is if someone has an ankle sprain, there's a 70% or more likelihood that they will re-injure that ankle and have another ankle sprain. That's because with ankle sprains, if it's not fully rehabbed to restore full range of motion, very commonly what happens is range of motion decreases with each subsequent ankle sprain, which makes you more likely to have the next ankle sprain. So, less range of motion means that when you go into a normal range of motion, that range of motion would cause an injury. So, less range of motion we have, the more prone we'll be to causing an ankle sprain. And unfortunately, many people have an ankle sprain and for one reason or another don't really seek care or follow through on physical therapy or do whatever it is they need to do to improve that ankle sprain and to rehabilitate it correctly. And so they end up with a less mobile ankle, and that makes them vulnerable to the next ankle sprain. So most ankle sprains are caused by excessive supination, causing injury of the lateral structures. So specifically, it's the inversion component of supination. So depending on what book you're reading or what you're studying, you might say that inversion causes the most ankle sprains. But as we know, inversion is next to impossible to occur in isolation. It's really inversion which is part of the action of supination, which is what causes injury to the lateral structure. So lateral ankle sprain is by far the most common type of ankle injury. Okay, calcaneal tendinosis. So as we've discussed in past videos, and tendinosis is where we have repetitive stress going through the tendon, which is breaking down the collagen faster than we can replace it with the correct type. So instead, we replace it with the incorrect type, the weaker, smaller type of collagen. And so over time, that tendon is becoming gradually weaker and less capable of coping with the same forces that the healthy tendon could cope with. Okay, so calcaneal tendinosis is happening in the same way as all the other types of osis. So it's degeneration of the calcaneal tendon caused by chronic overuse or misuse, causing the tendon to be repaired with the incorrect type of collagen. So the tendon becomes increasingly weaker and vulnerable to rupture. Okay, so this is commonly happening in the calcaneal tendon leading up to a calcaneal tendon rupture. So a person might not know they even had a problem in their calcaneal tendon. They might not know there was any tendinosis until it actually ruptures and it turns out that it had been degenerating and it was weakened, which caused them to have a rupture when exposed to totally normal forces that they should be able to tolerate. So, a calcaneal tendon rupture could be caused by a sudden tricep suri contraction. So, again, that would be gastrocnemius and soleus that result in a greater amount of tension than the calcaneal tendon can withstand. So, it would generally rupture under normal forces if the tendon is already pathological. So, if there's already tendinosis taking place, then normal forces can cause it to rupture because it's weak and not able to withstand normal forces, or it could rupture in a normal healthy tendon if it's exposed to abnormally high forces that it's not able to cope with. So someone who has a calcaneal tendon rupture, when you talk about the sensation of the injury, they'll almost always say that they were kicked. It felt like they were kicked in the back of their Achilles. So there will be no one around necessarily, and nobody actually kicked them, but it almost always causes the sensation of being kicked in the Achilles. And what they're feeling is that snap and that rupture of the calcaneal tendon. Okay, tibial stress syndrome has the nickname Shin splints. So this is something many of you may have experienced firsthand. Hopefully not. It's very painful. It can happen in different regions of the tibia depending on what type of forces are causing it and which muscles are involved in the condition. So it can happen in different places. So there's anterior tibial stress syndrome and medial tibial stress syndrome. And in both cases, it's what we refer to as shin splints. So what's happening is the muscles are yanking on the bone where they're attaching to the bones. They're yanking on the tibia. So the periosteum is that outer sheath, outer covering of the bone. And so when the muscles are pulling, it can cause inflammation of that periosteum, and that's periostitis. And that's what's happening in tibial stress syndrome. So then the question becomes, well, what is causing these muscles to put such excessive forces and yank so hard on the tibia? So it could be repetitive overuse, like running or training on a hard surface. So somebody, and especially when you increase duration or intensity too fast. So the muscles are pulling repetitively on the bone too hard, too often, faster than the bone was able to become strong enough to tolerate that intensity and duration. So you especially see this in people who are just starting to run, or maybe they've been running, but now they're starting to step it up a little bit because maybe they're training for something. Um, and especially if they're running on a hard surface, like if they're running on the sidewalk or on the road, like on pavement, then you especially will see this because there's more slapping on that hard surface as opposed to on a softer surface. Like if you run on trails, the trail will absorb more of the forces than that very hard ground. So on the hard ground, we're not having dissipation of the forces. All of that force is being returned to you through ground reaction force. Compared to in a softer surface, some of your muscle force that you're exerting into the ground will be dissipated into the different particles because there's less kind of solid ground there. So, like on sand, the muscle force that you're exerting into the sand is sort of dissipating into those sand particles. So, there's less ground reaction force being exerted back at the body. And so those differences in forces will affect likelihood of developing shin splints or not. Wearing incorrect footwear so that the biomechanics of how your feet are working and moving will also affect likelihood of shin splints. Insufficient muscle strength or abnormal muscle relationships or any kind of biomechanical abnormalities in movement all could result in tibial stress syndrome. Now, I want to emphasize that once somebody has tibial stress syndrome, the only way out of it is to stop the activity and allow it to heal fully before returning back to the activity again. So if it's caused by somebody running, or maybe they're running with the wrong footwear or whatever combination of factors is causing it, they have to stop the running, and then you can use ice and other therapies and things to try and allow it to heal faster. But returning to the activity before it has completely healed will cause it to just come right back full force immediately. Okay, so you have to allow it to heal completely. And once it's healed completely, you can return back to that activity, hopefully having made changes to maybe the surface you're running on or the shoes you're going to wear, or working on changing the biomechanics or your movement patterns that might be causing this. Okay, but returning to the activity before it is completely healed will cause them to come back immediately, which I know is hard for most people to hear because, like, especially if you're training for something, you don't want to hear that, you need to sit out for 2 weeks until it's all better. Depending on the severity, it might be better really quickly, or it might take a long time, depending on how bad it's gotten, and depending on what other modalities and things you might use to help it heal faster. All right, compartment syndrome. So that's when there is an obstruction of the neurovascular network that supplies a compartment. So when we have obstruction of the blood vessels and or nerves that supply one of the compartments in the leg. So the obstruction can be caused by increased pressure within a compartment that interferes with the nerve or vascular function. So this can be a serious medical emergency. It can put the structures within the compartment at risk. So as that pressure increases and it's blocking nerve supply and blood flow, it can essentially kill the limb. It can kill the cells of the limb because if they're not getting blood flow long enough, then those cells will die. And then that would require probably amputation, depending on the severity and how much the tissue is dead and all of that. So this could be a major medical emergency. So they would do a fasciotomy. That's what we see in the picture here, where you can, what not you can, I guess it depends what your modality is or what your training is, but where they would cut and allow release of that pressure. It would allow the blood and the fluid to escape to reduce the pressure to restore the normal blood and nerve supply. So that's a major medical emergency that needs to be handled immediately to avoid loss of limb. Now, with that said, that's in the case of an acute trauma that caused it. So some kind of car accident or athletic injury or something like that. It also can happen in a chronic sort of situation, in which case it is not a medical emergency. So compartment syndrome can also have a chronic misuse or overuse cause. So it can depend on the biomechanics of how someone's moving, or if they're overdoing an activity, then they can have a sort of compartment syndrome that sort of comes and goes, where like swelling will occur in a compartment and then that swelling will reduce when the activity is over. So in that case, it would not be limb threatening. It would not require a fasciotomy. It is not a medical emergency, but it's something that would sort of come and go depending on activity level. So it's still a problem that should be addressed by addressing the biomechanics and addressing the underlying cause of what the person's doing that's causing it to happen. And it would be painful because anytime we have reduced blood supply, that hurts. So not enough blood supply is an emergency in the body. And so that will cause pain because that's the body's way of saying, alert, alert, something bad is happening. Okay, so it's painful, but not limb threatening. It will reduce as soon as the activity is reduced. Okay, so pes planus, that is flat feet, like we see in the bottom picture here. So it's a lowering of the medial longitudinal arch, which if unaddressed, like with orthotics or in extreme cases, maybe surgery, but if it's unaddressed and you just leave flat feet alone, it can lead to a variety of other problems in the feet. So plantar fasciitis or plantar fasciosis also. Heel spurs, so like little growths of bone that are very sharp and painful. Patellofemoral pain because it'll cause the patellofemoral joint to track incorrectly. Metatarsal stress fractures because now abnormal stresses are going through the metatarsals at an abnormal angle that they're not prepared to tolerate. Low back pain, again, because it will carry all the way up the extremity, this abnormality. So it'll cause the patellofemoral joint to track incorrectly, which will change the angle of the hip, which will put a lot of pressure in the back. So it can cause low back pain. And then it can also, as I just described, cause any kind of dysfunction along the whole lower extremity because everything has to adapt to the abnormal position of the foot. Pes cavus is the exact opposite. So that would be an apparently high medial longitudinal arch. So we say apparent because there are different types of high arches. So when it's not weight bearing and you can see a high arch in the foot, that would be an apparent high medial longitudinal arch. But when you weight bear, sometimes that goes away and it goes to a normal height, and sometimes it doesn't. So in either case, if there's an apparent high medial longitudinal arch when you're not weight bearing, we would still call it pes cavus. But the difference is that there's different types, and it may go away with weight bearing or not be apparent anymore, or it may be very apparent and persist during weight bearing. So it depends on what is causing the problem as to whether it would reduce or not during weight bearing. So this can often be congenital. So it could just be by design of how the bones are how they grew. And it could also have neurological origin, like in cerebral palsy, or there could be a structural origin. So if unaddressed, it can lead to claw toes, which is exactly what it sounds like. It's sort of flexion of the toes that make them go into sort of a claw shape. Metatarsal stress fractures for the same reason as pes planus, where we have abnormal stresses going through the metatarsals at an abnormal angle that they're not able to cope with. And it can also cause plantar fascia rupture because there's so much tension in the plantar fascia that it can cause it to rupture during normal movement of the foot. Okay, plantar fasciosis. Again, like I've talked about repeatedly with tendinosis and other osis conditions, that would be a non-inflammatory degeneration of the plantar fascia where we have the breaking down of the collagen faster than we can replace it with the correct kind. So over time, the tissue is degenerating and becoming weaker. So this actually accounts for most cases of plantar fascia pathology. So where many people will be diagnosed with or self-diagnose with plantar fasciitis, in most cases, it's actually plantar fasciosis that is happening. So in most cases, it's actually not inflammatory. It's actually a degenerative condition instead. So occurs due to the same mechanisms as tendinosis, like I described. Versus plantar fasciitis, that would be actual inflammation. So it's significantly less common than fasciosis and can occur with significant change in intensity and duration of activity, prolonged standing, nerve or vascular entrapment, weight gain, or limited talocrural range of motion. So generally speaking, and this isn't always true, but generally speaking, plantar fasciitis tends to have a more sudden onset from a more acute cause, like maybe you're in Disney World and you're on your feet for 18 hours a day 3 days in a row, and now the bottom of your feet hurt. So that'd be like a more acute cause compared to like something that usually comes on over a much longer period of time. That would usually be more of a fasciosis type condition, but it really could go either direction. It just depends on that individual's response to some of the same stressors. Okay, tarsal tunnel syndrome is similar to like carpal tunnel syndrome or cubital tunnel syndrome. Same idea, but now here in the tarsal tunnel. It's entrapment of the posterior tibial nerve where it passes through the tarsal tunnel. So we're looking at the tarsal tunnel here in this picture. This is on the medial side of the ankle. So the tarsal tunnel is the flexor retinaculum over the tibia, talus, and calcaneus. So anything that causes basically impingement of the posterior tibial nerve as it goes through this tarsal tunnel would be tarsal tunnel syndrome. So it can be caused by acute injury or abnormal biomechanics, or even like tight shoes, like the wrong kind of shoes that could press in this area. Anything like that could cause tarsal tunnel. All right, phalangeal fractures may be caused by kicking in immovable objects like stubbing your toe, or a crushing force like dropping something on the phalanges. Now, just like we talked about with phalangeal fractures in the fingers, for some reason, these go underreported. For some reason, we seem to think that we can manage our own phalangeal fractures, whether in the toes or the fingers. So many don't seek care, or maybe not until much later, which is just bizarre. It's a broken bone. We should seek care for a broken bone, even if it's a small little bone like a phalange. Intermetatarsal neuroma. It's entrapment of a nerve between two metatarsal heads. Okay, so we've got these plantar nerves, these common plantar nerves that we see in the picture here, and they're going in between the metatarsal heads like we see here. So when there is a lot of pressure, like compressive force from the sides of the foot, compressing at the ball of the foot where the metatarsal heads are, that excessive compression chronically will cause a neuroma to form. So it's a formation of a fibrotic nodule and edema of that nerve. Okay, so most common in the third common plantar nerve, that's the one that we see the neuroma in this picture here, between the third and fourth metatarsals, but it can happen really in any of these nerves. Generally caused by chronic compressive forces in the forefoot. So generally it would be that kind of side to side compressive force on the ball of the foot. But then also, if you combine that with like wearing high heels, where you're shifting the force, more weight onto the ball of the foot too, that will make it worse and or more likely to occur. So of course, this can happen in anyone, but it is more common in women because of the footwear that is more common in women. So women are more likely to wear a tighter compressive shoe like high heels, and especially where it's shifting body weight onto the ball of the foot will make it worse. So anyone is equally predisposed usually to this type of condition, but women tend to have more environmental exposures that would cause this. Same thing with this one. So a Helix Valgus, progressive degeneration and subluxation of the first metatarsophalangeal joint. Okay, so that first joint where we're attaching the big toe to the rest of that foot, when it gradually degenerates over time and will subluxate slightly to form this valgus angle. Okay, so this medial angulation of that joint on the medial side there. So it causes development of a bunion over time. Now, I want to point out that this condition is Helix Valgus. So it's the degeneration and subluxation of that joint that causes this valgus angle. And over time, this condition will cause a bunion to develop. So they're not synonymous. They're not the exact same thing. The bunion is the enlargement of the bone or tissue on the medial side of the first metatarsophalangeal joint. So that is a result of this condition. So the condition happens first and then causes a bunion to develop over time. So that's what that big lump is on the medial side of the foot. That's a bunion. So caused by a hereditary disposition combined with biomechanical abnormalities. So this is another one that is really affected by the type of footwear. So you can see just by the shape of the toes that this is commonly caused by footwear that pushes your toes together. So another thing where we have compressive forces, especially like pointy shoes that are pushing the toes closer together. So if you're wearing those frequently, and then of course also if we add a high heel to that, so that you're shifting body weight forward, so we have more forces going into this compressive shape, that is going to be most common to cause Helix Valgus. Now, on top of that, you need to have the genetic predisposition that would lead to this condition. So that's why you could have two people wearing the same exact footwear over a lifetime, and one develops Helix Valgus and the other does not. So that would be where the genetic component comes in. But someone who is genetically predisposed without the biomechanical exposure, like the shoes, they're very unlikely to actually get this condition. So it generally requires both. So someone's not likely to get it without the biomechanical abnormalities. All right, a first metatarsophalangeal joint sprain is commonly called turf toe. So this is when the foot is planted and then we go into dorsiflexion. So with a planted foot and then we go into dorsiflexion or an extreme amount of hyperextension of that first metatarsophalangeal joint. Okay, so in this picture, the person is in plantar flexion. Okay, but imagine like you plant your foot on the ground and then you're moving forward. Your body weight is moving forward in front of your foot while your foot is still planted. To do that, you're going into dorsiflexion. Okay, so if your foot is planted on the ground and you are moving up in front of your foot, that means the angle between your tibia and the top of your foot is getting smaller. That is dorsiflexion. Okay, so you're moving in front of the foot and dorsiflexing. And the further you get, maybe your heel starts to come up. Now you'd go into some plantar flexion. But if you're pushing that first metatarsophalangeal joint into the picture, like we see here, into the position we see here in this picture, that is hyperextension of that joint. And that would cause that damage at the joint, like you see in the picture. And that is what turf toe is. So the joint is forced into hyperextension by a combination of friction between the shoe and playing surface, body weight, and forward momentum. Okay, so it happens like when you have cleats on and your cleat is stuck in the mud and your body keeps going. You've got momentum of, your body moving forward in front of where your feet are planted. So it's a combination of the friction of your shoe, like cleats or other types of footwear. So you've got friction keeping your foot down on that playing surface. And then you've got the weight of your body and your forward momentum going on top. And then you can sprain that joint, and that would be turf toe. All right. So thank you so much for watching, and I'll see you in the next video.